using as medical.
All these prices are not having. Yeah. It's just, just information. But that way, if you start from the store drug and you can write it down. Push dose cleanse is basically just IV and just, push it in there.
So
The IV on that.
double check the protocol, but according to Mark O'Brien, push doses are still there, but under medical control. Protocol specifically states that norepi and epi infusions must be by pump. That we know is
So
true.
the infusions need to be by pump.
So basically, any vasoactive medication that you're using as an infusion has to be on a pump, with the exception of dopamine, because of the clock method.
It's
Crazy world.
It
Yep.
doesn't say anything under here, under shock or medical control.
I'm too late. I got the protocols on my phone.
Yeah, I'm gonna get my phone. I know they, because I'm a 30 active fan, and I know they took their weight.
Yeah, because if that's something like.
Well, apparently, Marty says you can bring it up at the med services meetings and discuss it.
Yeah. I was thinking.
Because I would love to get phenylephrine back. Just saying.
Yeah. Well, we're seeing more and more septic patients in shock.
Well, that's the other thing too. Like epi is the kitchen sink, right?
Yes,
So you're getting chronotrope, dromotrope, and dromotrope all in one.
all at once.
And you might not want all of those. Sometimes you just need a little alpha. So
Yeah.
phenylephrine is great for that.
Yeah.
Just my personal opinion. Not that that's worth a whole
Yeah,
lot.
I appreciate that too, because that's what we do in the ER. Too.
Yeah.
We use phenylephrine all the time. Have a 15
We did start recording. Okay. So for those of you online, if you haven't seen the chat yet, go on ahead and put your name and your number in. I am writing down the ones that have already done so that I have you on the thing. As soon as she comes back, Mark has actually a reference for it.
Oh, does he?
Yeah, with regard to the protocol. 1.0, page 4 is thinking. When she gets back, we'll double check it.
1.0, page 4.
Let's see here, where's your number?
What did you do, Marty? You have that memorized, huh? So there we go. 1.0.
What do you say, 1.0?
Yeah, he says 1.0. He's thinking of somewhere around page 4.
Well, 1.0 is going to team patient. Everything says.
Anything in there? Or-
Everything that I'm finding, even under medical control options, doesn't say it. Everything that says anything to do with epi or norepi or dopamine, medical control may order epi infusion only, norepi infusion only, dopamine infusion. So all the epis are pump infusion only, and dopamine is the only infusion that we can hang without a pump. That's under medical control. It doesn't say that we're allowed to do push dose.
Yeah.
Well, you know, it's like everything else in the protocol.
I know.
It's clear as mud in the dark.
Yeah. You know how slippery that can be.
Uh-huh.
Even under
Yeah.
shock, right here, even under shock. So that's why Mark can tell me where he's finding it.
Keywords norepi and epi are bold. It specifically states infusions.
It says
Therefore, everything else
only.
is under
Yeah.
medical control.
Right.
So it's a gray area.
So
basically, is what we're saying.
norepinephrine, like even under shock, states infusion pump only. And then epinephrine, infusion pump only, or dopamine infusion. So the way I'm interpreting it is that you can, the only one you can free hang without a pump is dopamine.
Yeah, it doesn't say anything in there about, push
Because
those.
Colleen came up with this issue recently as well. And we were both talking about the protocol.
They say don't do it without an order.
Yeah,
Well, it was an order before anyway, too, before anyway.
yeah, something, yeah.
Well, you gotta be careful even with an order, because even though something is ordered by medical control, if it's still considered outside of scope or something, you can still get pegged for it.
Yeah, yeah, you
AKA
can.
New Jersey, for anybody that knows that story.
Yeah,
Was it the
they,
baby one?
medical director can get dinged too. 'Cause it's forcing the medic and or the EMT to do outside their scope and.
Here's the next physical roster for everybody that's going around.
Yeah, did everybody sign the first one?
Virtual.
Okay,
I think we get the same people for the most part, so I should be able to transcribe those two
All right.
together.
we ready to go then?
Yep, you are ready to go, Doc.
Okay,
Shoot.
thanks, Tom. This is, let me review this case. This is an interesting one. Both these cases don't have much to do with shock, but, they're really interesting in how they presented. And I did look up the outcomes on these too, so very helpful. This is, let's see, do some quick math. 61. Get to the other page here. Okay. This gentleman was born in 61. The dispatch for shortness of breath. So this guy is short of breath, and when he's found by EMS, he is tripoding. There's your first clue. This guy's really having trouble, right? He's tripoding, standing at his kitchen table, so he's probably leaning over in a forward position, and he's on his home O2. So we already know that this guy is oxygen dependent, COPD more than likely. Severe distress. He said that he was getting very tired, and he says it in very broken, gasping speech. He was able to indicate that he had a respiratory history, so he tells you what you already know. That he used his albuterol prior to calling you. So he's tried, so it sounds like he's been getting there. So that right away tells you it's not quite as sudden as like a PE, for example, but he's been gradually getting short of breath. He was immediately placed on the stair chair and a DUANEB was started, removed from the home by stair chair and transferred to the stretcher, secured. Unfortunately, the patient became more lethargic, closing his eyes. He appeared to be nodding off, falling asleep. So they had requested additional help. Second paramedic was sent to the scene. An IV was being started, placed on the cardiac monitor, and noticed to have a weak pulse. Okay, so his monitor shows sinus bradycardia. So this guy is like in the mid to low 50s. Do you remember this one?
Is it that line?
I don't know if you were on this call or not.
He's unresponsive, and then I bring him in, he's sitting up talking.
I'd have to look. I think it was he was Mark. And,
Oh, okay.
Yeah, Mark and Felicia.
Oh, okay.
Yeah.
No, it wasn't me.
Yeah. Not to take name because the outcome wasn't terrible, but eventually it was, but not for them. So no worries, Mark. I mean, I had it in the hot plate. So anyway, this guy is sinus. He's not looking good. So we'll stop right there. What do you think so far? Obviously hypoxic. Bradycardic, yeah, could he be going into shock?
Mhm.
It's very possible, very likely, yeah. Cardiogenic, maybe? Yeah, bradycardic. How's his oxygen delivery? What do you think? Compromised, yeah, pretty bad. So this guy needs O's. I think it was wise of Mark and Felicia to place him on some albuterol treatments, doesn't hurt. Albuterol, as you all know, is a bronchodilator. It helps to open up the pipes to maximize the airflow, oxygen in, carbon dioxide out. Good move on their part. This guy obviously may need something to make his heart rate go up. Like that was atropine, right? Make that sinus node work a little bit harder. So the guy is also placed on pacing pads, appropriately so. Do you think he'll need external pacing if he doesn't respond to atropine, of course.
Good job, Felicia.
Yeah. So she and Mark are on the ball here. They did give him not one, but 2 doses of atropine, 0.5 milligrams, and they initiated transcutaneous pacing. Mark says that when the pacing was applied, there was some electrical capture at 100 milliamps, but mechanical capture and corresponding pulses at 140. So this guy was demanding quite a bit. Good positive effect. They get a good heart rate, and the guy's doing a little bit better. He did not regain consciousness. Unfortunately, a second paramedic truck arrives at the scene. This guy's airway is already compromised. Now his heart is compromised. What happens to cardiac output? Down the tube. So we're losing oxygen, losing carbon dioxide, or cardiac output. So guess what? This guy is getting worse and worse. What's your next step? Go back to the beginning, ABCs. Are you going to intubate this guy? Yeah, very well. He's obtunded now. He's not breathing well, and we're losing ground fast. So to secure the airway, that's a wise move. Intubate this guy. Intubation was achieved and placement confirmed by auscultation, mist in the tube, bilateral chest rise, and capnography. Excellent. I love it when you guys document that you know the tube's in place. Why? That's very important. Endotracheal tube is secured. End tidal was initial was 105, and then he was ventilated down to 45 and 50. It's no wonder his end tidal was 105, right? What did we have right before we intubated this guy? Tripoding, decreased responsiveness. You know, when a person goes to decreased responsiveness, what happens to their ventilatory rate? It drops, right? When you fall asleep in a deep sleep, your breathing rate really slows down. Any of us asleep with a spouse or a mate or a kid, you know that happens. You know, sometimes you nudge them because it doesn't look like they're breathing. So ventilation will decrease. Good call on their part to ventilate up to get the carbon dioxide out. Successfully ventilated. Report was given to the ER and transferred there. And unfortunately, this guy arrested. So the arrest situation in the ER, the guy was successfully resuscitated. We did get ROSC, and the patient was secured there, and then he was transferred to UMass. Upon transfer to UMass, the guy was found to be, well, we found this right before he transferred out. He was found to have an anterior wall myocardial infarction. So this guy had ST elevation in what leads?
Anterior?
Anterior.
E5 and 6, well, 4, 3 and 4.
Yeah, 3 and 4, or
Yep.
1 and 2. He had 2, 3, and 4. Absolutely, so the whole front. Right. So he had an anterior wall MI in addition to everything else. Now, what came first, the chicken or the egg? Did the MI make him short of breath? He subsequently succumbed, or did his hypoxia from his lung disease set up a heart attack? You know, anybody's guess, and anybody would be right with both answers. You know, if that were on a multiple choice test, you could check all of the above, because one could lead to the other.
No, that'd be a registry question, and you only have to pick, you can only pick one.
Yeah, yeah, you know it.
That's what that would be.
So follow up on this guy. I looked him up in Epic. He got to UMass. Sure enough, he was in the anterior wall MI, blew the ventricles. I think they tried PCI on this guy and opened up his LAD with a drug-eluting stent. Unfortunately, it didn't work very well. The guy succumbed 6 days later. So he hung on there for about 6 days after arrival to UMass. I don't know if he was organ donor or not, but he just later succumbed to his illness. A lot going on, and this guy was diabetic as well. I think, if I remember, he had hypertension. Not a picture of health, unfortunately. So even at his younger age. So just thought I'd review that case because it had a lot of multiple elements in it. You see that? As I told you, our patients do not read the textbook. So it's nice to go through an actual case and tell you all these elements. Because if you're thinking all heart and ignore the lungs, or you're thinking all lungs and ignore the heart, or you're thinking all heart and lungs and ignoring the fact that the guy's in shock, you're missing the boat. Fortunately, the crew that took care of this patient were right on top of this. They recognized that the guy was heading downhill quick, administered appropriate oxygen, IV access for atropine to bring the heart rate up. Why do we bring the heart rate? Because heart rate times stroke volume, or cardiac output rather, equals blood pressure, remember? So it's very important to get the heart rate up to increase the blood pressure. This guy's initial blood pressure was pretty high anyway. So everything was ticking, but unfortunately this guy went on to infarct and had a heart attack.
Mark says that they were in the process of getting the 12 lead when he got worse, so they had to rip off the electrodes to get the defib pads on.
Oh, okay.
So apparently they didn't get to the 12.
Yeah. Yeah, I appreciate his input. Yeah. Good job, Mark. I'll give you an A for that one. I suppose you want extra credit, but
Well, pretzel.
I'll see what I
Setting
can
up a
do.
pretzel.
Yeah. Yeah.
Our
Maybe,
Christmas pretzel.
maybe chocolate covered
I
pretzel.
don't know, it's waiting for Christmas.
Oh, there you
go. Yeah.
Go some Christmas.
I'll take
It is
a look.
Christmas time. All right, this is a case I was personally involved with. That's why I pulled it, so I can put me on the hot seat just in case anything went wrong. Fortunately, very good outcome, good calls by the crew. So this was a September case, so it took a while. I had it in my pile of I would like to present one day. Okay, so this is, I should remember his age, but like I said, maybe I'll do better trying to put slides together. Oh, here we go. 68-year-old male. You get called to the scene because this guy is a truck driver and he's actually washing his truck and in the garage bay, and he's up at least on a 10-foot ladder, so he's up at least 10 feet washing or doing whatever. Well, wouldn't you know, the ladder slips and he goes falling down at least 10 feet, plus this guy's about 6 feet tall, so that's about 16 feet in total. Lands on a cement surface and he lands on his left side. He's awake and alert and not lose consciousness. His son is in the area and he hears this thud in the crash of the ladder, of course, and comes running. So he has immediate attention, and he finds his father on his left side complaining of shoulder pain and my ribs hurt. And that was it. You know, just don't let me lay here, get me up. Son says, no way, I'm calling 911, I'm not moving yet. So EMS arrives, they get the scene, they find him awake and alert, GCS at 15, complaining of the pain in his shoulder. It's right up here, and he's pointing up here, and he can't move his arm, and it hurts right here. He's breathing okay. I'll give you his vital signs in a minute. Let's see. He was, yeah, that I'm reading. Theirs, not mine. Well, here we go. Yeah, my vital signs. He was a little hypertensive. He was like 148/60. Heart rate was like 110, so a little fast when he came in. I attribute it to his pain and anxiety. Respirations were 18. He was well saturated in room air. He's around 96, which I thought was darn good considering. And his color looked good, although he was diaphoretic. He was starting to sweat. Okay, so let's stop right there. What's in your differential? Without you guys, I'm not even giving you much in the way of a physical exam, am I? What do you think?
Well, like height of the fall,
Yeah, height of the fall makes you think.
trauma, or like pneumo.
Yep. Yeah. Yep.
Compressed.
Shoulder pain. Shoulder pain could be direct shoulder injury. You know, fractured humerus, clavicle,
Pulmonary
scapula.
contusion.
Yep. Pulmonary contusion. Possibility of a pneumothorax, maybe.
Started.
Yep. Pneumothorax, multiple rib fractures. Yeah. Could he have ruptured his spleen, maybe?
Absolutely.
So, always possible. Yeah. Now, he wasn't complaining of any head strike or head and neck injuries, but are you going to assume that he hurt his neck on the fall? Absolutely. Good for you guys. Are you going to bring this guy in a collar?
Yep.
Yes, and they did, which was really good. The crew brought him in with a neck collar in place. and we gently slid him to the bed. Now, here's what I found in physical exam. Head and neck exam were perfectly normal. I didn't feel any cephalohematoma, no bruising, no edema around the face. Neck palpated fine through the collar. Needless to say, I didn't take the collar off. Can I clear or you clear the C-spine based on the mechanism and what you're finding on exam?
No.
No. So don't do the protocols. You can't nexus criteria clear this guy. All bets are off. So because he has distracting injuries, right? So I couldn't clear the C-spine. He's got a palpable deformity of the clavicle here, bruising, ecchymosis. The shoulder, the humerus looks okay, but it's sore to the touch. Scapula looked okay. I didn't see anything or palpate anything really weird there. Sure enough, when you come down the chest, it's very tender, and there's beginning a little bit of crepitus over the skin. You know where this is going, right? The lungs are a little diminished over here versus on the right. Heart sounds okay, a little tachycardic, as I said. Abdomen non-distended. He has no bluish discoloration around the umbilicus or in the flank. Pelvis is stable. Extremities look fine to me. His neuro exam is normal. He's got an NIH of 0 and his GCS is 15. So that's it. So the next step, I'm going to pan scan this guy. Because of the fall, the mechanism, and the injuries, I'm going to scan him. Head and neck scan are normal. His CT chest is abnormal. He's got a fractured clavicle, displaced and angulated. The humerus looks fine. The scapula is fine. He's got multiple rib fractures, 5, I think it was 5 through, let me see. No, I don't remember now. Oh, come on. All the palaver, you know, UMass, they talk about everything.
Was he given any pain management?
5 through 9. Oh, yeah. The cruise in gave him fentanyl. We gave him some more fentanyl. I think I sent him, you might remember, I don't have my chart in front of me. I gave him some Dilaudid before he left. We also gave him fluid. This was back before the shortage, but you know, any trauma patient, all bets are off. When you guys have a trauma patient and they look like they're bleeding or could bleed, you're dealing with possibility of hypovolemic shock, correct? So when you hang fluids on a trauma patient, no one will fault you for that. You know, it's very appropriate. So
Did he have a flail segment with those ribs, or they were just?
no flail segment. They were singular fractures. He was fortunate. Singular fractures 3 through 8. He sure enough did have subcutaneous emphysema on a CT scan. He had a little hemothorax. There was bleeding in the base, and he had a pneumo there, a moderate pneumo, which they put a chest tube in him when he got down there. They don't give me a percent, they just said moderate. So we'll take that for what it's worth. So this guy had a hemothorax from trauma, technically more than one rib fractured, would put him in somewhat of a flail, but by definition, by strict definition, a flail is 2 or more contiguous rib fractures broken in 2 or more places. So take that for what it's worth. Flail chest gets the same treatment as he did. It is just a chest tube. Needless to say, they watched him for a couple of days. His CT abdomen pelvis was negative. He didn't have a splenic lac. I was super surprised, you know, because of the nature of the injury. Liver was fine. The splanchnic architecture, in other words, the gut was all intact. No vessel injury, which was good. Pelvis and lower extremities normal. So wonder he didn't break his hip when he fell too. But yeah. So I thought it was a good case. Points to take in stride. The retrospectroscope, as you know, is 100%. We can always see very accurately when you look back on things. Initially, this guy did fall 10 feet or a little bit above if you count his height, which we should always do. So by protocol, technically he should have been run to a trauma center. However, that being said, you're right at that break-off edge of, do I go trauma or do I go to Haywood? I think the crews made a good split decision to bring him to us because he didn't look terrible. He was complaining of a lot of pain, but as I told you, he had pretty stable vital signs. So he didn't look sick. He had the potential to become sick, but he wasn't like over the top. So I think in retrospect, this guy was a good candidate to come to us for us to see if indeed he needed, maybe he only broke one rib. Maybe he had broken ribs, but no pneumo. Maybe he had just a contusion of his shoulder. So things could have been better, but things could have been worse. And if he had a splenic lac or more trauma that we're dealing with or torn his aorta, we could have stabilized him and then flown him out or transferred him out. So it doesn't matter in this particular case. So I'm not going to nail down or hammer the crew that brought him in, but just a learning point. Another thing too, and some of you have done this, you call in and say, Doc, this is what we have. Do you want us to divert and go to UMass, or what do you think? You want us to bring him in? So it's a judgment call, and I'm not you. I'm not there seeing the patient, and I will not fault you if you made a decision, good or bad, because if you have to do it in split seconds, you don't have the time. You know, say, Daniel, call you in an hour. We're going to sit down and think about this. So open up my protocol book. I'm going to go home and get my textbook and then go back to the scene. And I'm just kidding. So I appreciate you guys making split decisions like that. And if you have to bring them to us, that's perfectly fine. An obvious trauma like that. Remember that one we had last time that had the door blown off the car? You know, that's pretty straightforward. Oh, I think I'll take him to Athol. And it's like, no, you won't. Flying from the scene. But so that was a good case. Yeah, he had a little bit more trauma than I expected, and he had a little less trauma than I expected. I thought he'd blow some solid organ there. Time for one more, you think? Sure, 5 to 8. Yeah.
Also, real quick, not to cut you off if you don't mind.
Oh yeah.
So Brian actually did find, there is, like Tom said, everything's clear in the mud. There is a small little part under 1.0 that almost kind of like recants what the state is saying. Because it says, on occasion, good medical practice and the needs of patient care may require deviations from these protocols, as no protocol can anticipate every clinical situation. And in those circumstances, EMS personnel deviating from those protocols should only take such actions as allowed by their training and only in conjunction with their online medical control.
Oh.
So you're
That's
obviously
great.
the boss.
So
So
that statement oversees all the protocols.
correct. It's just like Mass General law. They tell you one thing, and then so you're the boss. How do you interpret that? That
Yeah.
you're okay with us still doing press push dose with medical control,
So we could.
Yeah. and you don't even have to do the waiver.
Where's that at?
It's section 1. It's
Oh.
down.
Right at the beginning. Yeah.
It's on the 4th page. 1, 2. Yeah, on the 4th page, halfway down.
Section 1.4, page 4. Good. That makes me feel better.
You just
Because-
have to make sure that whenever you use that particular caveat, that you have a good, solid,
Reason.
medical standing. on
No,
it.
I
You
understand
know what I
that,
mean?
but that's
That's the only thing,
Yeah.
because otherwise the state could potentially rake you over the coals.
Yeah.
So as long as you have good medical standing, you know, in your argument as to why you're doing what you're doing.
They're septic, they're hypotensive, give it to me.
Yeah. Yeah, if he's still in shock after his fluid balls.
Well, that's what I'm saying. So, like I said, you're obviously, at the end of the day, the boss.
Yeah.
However you would interpret that.
Or if the shock state is putting him in more trouble, you know, now he's bradycardic, or, you know, he's gonna lose his airway, that sort of thing.
And then any deviation from protocol, as Mark is saying in the chat here, is something that should be going to you as a call review,
Yes,
regardless of
absolutely.
whether or not.
any and every run that goes outside protocol has to come through me. Has to.
So at the end of the day, are you
Because
still
it's-
okay?
It's my job to make sure that if we're outside of protocol, that we cross our T's and dot our I's as to the documentation as to why, so that OEMS won't breathe down our back or investigate it and get us all in trouble. So, and we want to make sure patient safety is number one. Yeah, that's good to know. And we can apply that into a lot of other protocol situations too, man. This is a patient, 83-year-old woman who presents to the emergency department. She was brought in by EMS. She was presenting with, let's see, got 2 Virgos. This is my chart too. Chief complaint was I don't feel good. I'm nauseated and I'm dizzy. And she was actually found by family to be a little more lethargic than usual. That's what prompted her husband for the 911 call. So this antecedently or before all this, she's just not feeling good. She becomes kind of lumpy dumpy, husband calls. And the report on the run sheet said the heart rate was in the 30s. So this lady's found severely bradycardic. She's meditating. They gave her a total of 1 milligram of atropine in 2 half-milligram increments, which is appropriate. The only time you slam one is during an actual code, right? She didn't improve very much where she was meditating. Didn't perform any other interventions, and they also told me that she's DNR and DNI. That doesn't mean we don't treat her. That means, you don't have to get too excited about intubating her. No headache or vision changes were reported by the husband. No recent URI stuff. I did find out that she's normally on diltiazem, which is a calcium channel blocker, and she's got underlying AFib, as well as Sotalol, which is a beta blocker. Gotta go. Thanks for coming. 120 twice a day. Her cardiologist has just increased her diltiazem and doubled it to 240 milligrams a day. One of the side effects of calcium channel blockers is to slow the heart rate. Bingo. So there's your answer. Yesterday morning, the morning before her presentation, she took 120 milligrams, and then in the evening, she took her new dose of 240 milligrams because the doctor or the doctor's office didn't make it clear that that's supposed to be your new daily dose. So now this lady has taken her 120 plus the 240. So guess who's toxic on calcium channel blockers? What a case, huh? Wow. So this is a tox case. This turned the corner real quick. When we found out the history, and this was soon after arrival, it was like, oh, that changes the picture and explains the bradycardia. So she was, on arrival, she was 34. Her blood pressure, well, I'm surprised, was 96/60. She soon went to 83/43. Pulse ox at 97, 92 at the worst. And her blood pressure improved. Let's see, we got her pressure up to 106, then to 109. Eventually got to 145.
Is that with fluid or calcium?
Yeah, we were giving her calcium. That's what,
Gluconate or chloride?
calcium chloride or gluconate. I'm sorry. She got 4 grams of calcium gluconate, and we put her on dopamine. Very obvious reason. We felt she was in cardiogenic shock. Calcium gluconate is a choice because calcium channel blocker, right? It's blocking any calcium influx into the cell. So by giving her more calcium, we're overriding that blockade and loading her cells with calcium. And the dopamine is just a supportive inotrope until the calcium starts to work. Yeah, Tom, we gave her 4 grams to start and then another 2 grams. So she had 6 grams of calcium fluids, of course, and a little Zofran, just for that's the cherry on the Sunday.
Right.
So this patient took triple her dose of calcium channel blocker, and she is also on Sotalol. Remember I told you? So Sotalol is a beta blocker. So this poor lady is super blockaded. That's why her blood pressure's in the toilet, her heart rate's in the toilet, meditating well, but blood pressure is this. So we gave her the calcium gluconate and lots of it, fluids. That's what you do. And the calcium is also helpful in beta blocker. Severe beta blocker toxicity, what's your antidote? Do you remember?
Glucagon.
Glucagon. Very good. So transcutaneous Baker was on standby, but we didn't have to use it, ironically enough, because the calcium made a difference. Why? Because that's the problem. We're blocking the calcium. We're treating the problem with calcium. She was in slow AFib, and needless to say, her trace looked like this. She was like, with a hypocalcemia, you can imagine. Yeah. So the AFib, the calcium made a difference. Her lactate was high. Now, why would her lactate be high? Because was she in shock or not?
Well,
Obviously,
absolutely.
yeah, she's a shock
She's
patient.
an anaerobic.
Cardiogenic, right? Cardiogenic shock. So her lactate would be up because her oxygen delivery is compromised. She's getting plenty of oxygen. Remember, her pulse ox is 94 or so. So that's good. She's getting the oxygen she needs. She just doesn't have the pump capability at 37 beats per minute to deliver the goods. Yeah. So the Amazon drivers are at strike. They're not delivering the goods. So all the widgets are in the warehouse, but they're not going anywhere. So we took care of her in short order, needless to say, admitted her to the unit. And she did get better. And there was a lot of education behind how you take your medicine. Not her fault. She was misinstructed big time. Just in the way of fun, her lactate, I told you normal is 2, anything above 2 is not good. She was 6.4 when she first came in. Her calcium, surprisingly enough, was 9.2. I have a hunch that was measured after needless to say, we bolused her right away. Calcium and phosphorus help each other with bone building. When one goes in, one goes out. So if the calcium was going low and being blocked or going too high, phosphorus would go in the opposite direction. Her phosphorus was high at 5.2. So that's why I would have expected the calcium to be a little bit lower. Little liver shock, transaminitis, AST, it normally should be 32, hers was 222. ALT should be 33, hers was 104. Her trope was elevated. Are you surprised? The troponin, which is in the muscle, the myocardium, was being leaked out because her myocardium was working so hard. And you can imagine she's got a little heart failure, of course. Her B natriuretic peptide, instead of being a ceiling of 300, was 3,304. She was a little hyperkalemic, no surprise. What happens to those cells when they're not getting the oxygen? Do they leak potassium? Yes. So her potassium should not be higher than 5, and hers was 5.6. And that we didn't address directly, but we sort of did with the calcium. We were focused on calcium blockade, but calcium gluconate is also used for hyperkalemia, correct? We use calcium gluconate, insulin, and sodium bicarbonate. Or bicarb, by the way, would it be high or low? Would she be acidotic? Cell death? Yeah. She'd be metabolic acidosis. So her bicarb is 19, and bicarb should be 22 to 30. So sure enough, she was acidotic. Renal function, BUN, compromised. BUN is 29. Her creatinine is 1.55. A little up. Interesting case. She kind of flows in with everything we talked about, right? So outcome was very good. She got what she needed and away we run.
Did her AFib get corrected once her?
Yeah, her AFib rate got up, but the AFib was chronic for her, so she's always in AFib.
Oh, okay.
But the
That's
ventricular response to the AFib was improved.
But it got,
Yeah. Yeah, her sinus nodes is long gone. Yeah. Yeah, she just defibrillates from wherever she wants. Interesting case because, as you know, our patients are polypharmacy anymore. So they come in with a boatload of drugs. And the problem is that a lot of those drugs bump into each other, or the patients' families, or even the visiting nurses get all confused as to what starts, what stops, what goes up, what goes down. And the next thing you know, we're poisoning our patients. So in February, I've been asked to do grand rounds at the hospital. Every Wednesday at 8, we have grand rounds, and it's on Zoom. It's a presentation of various topics. Some of the topics are kind of boring, like child care for the sick patient or whatever. But some of them are very clinically adept. In February, I'm hoping to do a prescription pad that is deadly, or prescription pad that kills, and talk about bad drug combinations that we actually unintentionally give our patients, and we can put them in peril. Because I can write a prescription for something, the next thing I know, I'm giving you a 911 call. And that's not nice of me to make you guys work. Yeah, I don't like to do that. So what I'll try to do is, as we get close to that, maybe share that Zoom link with all of you. You can chime in. That way you don't have to be there, because we usually do it out of the library at the hospital. But since COVID, no one comes, and as we get more participation, I don't know if it's now Google Meet or on Zoom, that it's set up by Sandy Fleek. Sandy Fleek is our librarian at the hospital, so we'll set that up. And I don't know if you guys can get credit for that or not.
I don't see why you wouldn't.
Yeah. So, yeah, as we get closer, it'll be something big. So instead of me doing it twice, if you guys want, you could Zoom link in on that one. Or if the feedback from the EMS is that you want me to do it as part of an M&M, we can do it that way too. So,
That would be neat.
yeah, I can do it as an M&M. And that way I'll do both, and you have the option of doing both. Yeah, so maybe my next M&M could be doing that. I had a couple other ideas to run by you too. One was on maybe doing like a pain management talk, how do we manage patient's pain in the outpatient setting or pre-hospital. I forget what the other. So if you guys have any ideas or suggestions or want me to present any topic, probably what we should do in the near future too is something pediatric.
It's like concussions.
Yeah, we did concussions not long ago.
Yeah, we
Oh,
did
okay.
concussion.
Yeah. Yeah, was that the last one or the one before was head injury?
I don't remember.
Yeah, stroke was the last one. I think we did head injuries before, but yeah, some kind of pediatric something. So I've got a couple talks I did for EMS in Vermont. Airway, that's a big one because, kids in air trouble, respiratory trouble, trauma in children, altered mental status, orthopedic injuries. We could pull something out. Okay.
Yeah, we're going into RSV season. And
Yeah. All right, very soon, I'm going to look at my calendar for 2025. I'll set some EMS or M&M dates, and through your EMS coordinators, I'll get those out for you. Who's your EMS coordinator? Who is it?
Bill Clayton.
Oh, that's right. I've got Bill's email.
Yeah.
So,
And that's all it's concerned with.
yeah, Kelly did that. Okay. And that's
You
one.
got mine?
Peter, and Templeton is Peter.
Yeah. Yeah, I've got all their emails, so I'll send out, I meet with the EMS coordinators on a regular basis, just to go over things and make sure we're on the same page, which is really great. That way I'm communicating there with you, and, I'll make sure that they know when M&M is, so. Thank you all, thank you for coming, thank you out there in Google Meet land.
all right. Winchendon, I'm assuming everybody that was
Oh,
present
yeah.
for session 1 is there for session 2. I do.
Yeah, great.
Eighty-one, 37.
I lost my.
37?
37, yeah.
At-
At gmail.com.
Okay.
I will put you on that too.
Oh, yeah, totally reviewed.
Very good.
Search clearly.
Take care.
Thanks, Tom.
Marty
Thanks very
suggesting,
much, appreciate your comment.
Marty is suggesting a 12 lead review, trauma, PD, or surgical airways.
Oh, yeah, I need that pen again. Just for you, Mark. 12 lead for sure. Now, some EMTs,
Yeah, the
Yeah.
basics would be kind of left out of that.
but I've done that before. What I do is I throw in a little rhythm recognition and tell them,
Sure.
you're just learning this, right? So 12 lead, what else?
12 lead, trauma, pediatrics in general, and surgical airways. One of my personal favorites, actually.
Yeah. Yeah,